As department head of otology. He has a great experience with acoustic neuroma surgery with cochlear implantation. Thank you, sir. And sir's topic is new developments in cochlear implantation.
Thank you very much. Congratulations again on a milestone, 25 years. It's a pleasure to have this opportunity to talk again, and in new developments it's interesting to review the past to some extent. And this was the computer that was used back in 1978 to test the speech processing and coding strategies. And it was this that allowed to demonstrate that place versus pitch. Low pitch was at one end of the electrode and high pitch was at the other end, and that the loudness that the patient perceived was directly related to the current level. And Sunil showed this picture yesterday. I'm not sure where it came from in your slides, Sunil, but this was the first wearable sound processor or speech processor. Graham Clark extends his congratulations for the 25 years. Graham is still well, although getting elderly. And this is the current version of the external processor. But the dramatic thing about cochlear implantation is how the outcomes have continued to improve. And I believe it's a whole range of factors. Younger age of implantation, the use of binaural hearing that we've just been talking about. It's very clear if you do better if you hear with two ears rather than one ear. Because we're getting better outcomes, more patients have more residual hearing. That means that they have better neuronal populations to stimulate, and hence the outcomes get better and better. So it's a continual process. The technology continues to improve. We can preserve hearing, and so we can combine electric and acoustic stimulation. We're learning more about optimal electrode insertion and position, as we discussed yesterday. And the indications are expanding, as we've just heard from Ganesh, such as in single-sided deafness. So I'd like to briefly cover many of these topics in this talk. In Australia, on the East Coast, there's three very significant early intervention centres, which each collect long-term data on the outcomes of children at different stages, preoperatively, after implantation, and then at preschool, then at school entry, and then during their schooling. And it's studying those outcomes in terms of language development has allowed us to assess who will do better at what age. And it's very clear from this sort of data that children who receive their implant under 1 year of age have more normal, this is receptive language, at school entry. So the younger children are clearly doing dramatically better in terms of their speech and language outcomes and their speech production. And so reviewing our data from these various centres does show, and it's key, that whilst if you receive an implant before 2 years of age, then that allows optimal speech perception. But in order to get speech development and speech production, those that get the implant younger than 12 months are doing significantly better than those who get it before 2 years. And those children who get it younger than 12 months can in fact be very, very similar to their normal hearing peers in terms of language development. So I can't emphasise enough that in terms of neonatal screening, we need to then progress that to early intervention. We've just been discussing how the neural anatomy is very important, and it's very clear that to get good outcome, we need to have normal anatomy, and we demonstrate that on MRI scanning. And if we see a normal nerve and normal structure on MRI, then we don't do CT scans. For young children, we avoid CT because of the concern about radiation, because we can tell that the anatomy is normal, and surgically we find the anatomy rather than needing to demonstrate it in advance. But conversely, if there is a dysplasia or a cochlear abnormality, we want a CT scan to look more closely at the anatomy. The recognition that if there's a nerve deficiency has a major impact on outcome, and we've discussed again yesterday in relation to selection to ABI or cochlear implantation. If the nerve is abnormal, then you have to appropriately counsel the families about that. And of course now genetic testing has a major role, and we can predict also if they have connexin as a cause for their hearing loss, then we know that that will be associated with normal anatomy, for example. And again, we hear better with 2 ears. And so that can be bimodal, and if we have a cochlear implant and a hearing aid in the contralateral ear, then that hearing aid must be appropriately managed and optimised to get good outcome. It's got to be balanced in terms of loudness with the cochlear implant. And as we heard from Nikita, the matching of the sound processing between the hearing aid and the implant is now significant. So phonak and AB or resound and cochlear do make a difference. And for bilateral cochlear implantation, most of our children are either simultaneously or sequentially implanted. And it's only those who have aidable hearing in the contralateral ear who don't get bilateral implants now. And even in our adults, more than 20% of our adults are now bilateral recipients. It's interesting to look at our academic outcome. You know, this is for implant children at 7 or 8 years of age, their school outcomes in terms of language, mathematics, writing and reading, or overall total. And this is compared with the normal hearing equivalents. And as you can see, the cochlear implant recipients are doing very, very well. You know, the majority are up in the normal range. But it's interesting to break it down between those who have bilateral implants in green versus the unilaterals in blue. And the bilateral recipients are again doing better. They're more within the normal range than the unilateral. As Ganesh was saying, I think there is a critical period for bilateral implantation, and this we've learned about that critical period for binaural processing, because there's a big difference between binaural hearing with 2 implants and bilateral hearing with 2 implants. And whilst you can get a benefit with delayed second side bilateral hearing, you won't ever get binaural processing and good sound localization. To do that, you have to receive the second implant within 3 to 4 years. If you're older than 4 years, there's probably a window which you won't get binaural processing. Doesn't mean you won't get a benefit, but you won't get true binaural processing. So in the past, we were implanting children and adults who had corner audiograms or no hearing at all, and this is where things have dramatically changed. We now see many of our both adults and children who have audiograms like this. They're a pure tone average of 70 or better, often sloping, sometimes flat. So how do we tell if this patient is going to do better with a cochlear implant than with the hearing aids? And the key is in the speech perception testing. And as you can see here, we've got CBC words and phonemes, individual ear testing, and they're doing quite well, 75% phoneme scores, and they get a binaural advantage as well. So we have to assess whether if we take away one ear, will they do worse? And we now look very carefully at their sentence reception thresholds, both unilaterally and binaurally. And so we compare an individual with our past experience. And so this is for 280 recipients, for adults with implants, and their median speech perception is 89%, and first quartile is 61%. And for monosyllabic words and phonemes, again, we look at this first quartile, so 75% of patients are doing better than 55% words. First quartile here, I can't quite read that, 26% words. So we can then use these outcomes to predict that if you have a score of less than 55% phonemes, then you've got a greater than 75% chance of doing better with a cochlear implant. And that's the way we pitch our candidacy, and we can gradually adjust our candidacy over time. So no longer are we looking at the pure tone audiogram so much, we're looking at their speech perception. And we've just heard a lot about single-sided deafness. So many patients not only have asymmetric hearing loss, but some have normal hearing in the contralateral ear. And we're looking now at the their worse hearing ear, we don't necessarily take into account their thresholds in the better ear when advising about an implant. But we've studied a smaller number of adults than Ganesh, and the results are somewhat similar, but our interpretation is perhaps a little bit different. So this shows the group of nearly 40 adults preoperatively. When speech is presented to the bad ear, the cochlear implanted ear, they get a significant benefit post-operatively. The speech reception threshold drops significantly. But even when the speech is to their good ear, to their normally hearing ear, there is an improvement between pre-op and post-operative, but not such a dramatic improvement. Their localization also improves post-operatively, but it's not a hugely dramatic improvement in localization, but they can, at least in the laboratory environment, show some improvement in localization. And tinnitus also improves, but once again, it's not a dramatic improvement. And I think that whilst Ganesh said that it's very worthwhile for patients, we will not implant a patient whose major problem is tinnitus. We will implant patients who are concerned about their unilateral loss of hearing, and they're struggling with their hearing, and they want to improve their hearing, but they also have tinnitus. But if they come along saying, I've got to get rid of my tinnitus, then they are a bad population, and you're not likely to abolish their tinnitus, and I'd be very cautious about implanting those ones. So to summarise our single-sided deafness experience, the speech reception threshold improves to both the bad and the good ear. There's significant improvement in localisation, but a big amount of individual variability. Significant improvement in tinnitus, and again a big variability. And interestingly, the phoneme scores for the group using their implant ear alone is equivalent to our average implant outcomes. And again, patient satisfaction is variable, although the majority are wearing their implant for 8 hours a day, so it is useful, they are using it. Some didn't notice any significant benefit in noise, and some of them even remove the implant when they're in a noisy environment because it brings in too much noise and it becomes confusing. So it's certainly not a cure-all in the noisy situation. But many of them commented that they hear more easily, they are less tired, less listening effort, that sort of thing. And interestingly, the scores, their speech perception scores, don't necessarily correspond with patient satisfaction. And whilst those with longer duration of hearing loss still get a benefit, we found that those with shorter duration just have a greater satisfaction score. So moving on to technology, there's been numerous generations of cochlear implants, both in terms of the internal device and the speech processors. And I always like to show this slide, which demonstrated that for the first 20 years almost, there was a stepwise improvement in the speech perception outcomes with the different sound processing strategies. So improvements in the sound processing and the method of stimulation directly resulted in improvements in the hearing. But more recently, it's been the pre-processing technologies, and the objective is to improve the signal-to-noise ratio, and everything is related to really improving the signal-to-noise ratio. And noise sources vary in type and in location, and any technology to do that, to reduce that, must address both of these. And that can be due to improved hardware. In particular, dual microphones on the processors has made a dramatic difference. And the digital signal processing also then allows for focused hearing, such as the beamforming and ADRO, or the adaptive dynamic range optimization. And the wireless connectivity is another dramatic method in which the signal-to-noise ratio is improved. And this allows technology such as the phone clip or mini mic or direct streaming to a TV stream and things like that, or direct connectivity with the hearing aids. And an example where this is very useful is, for example, in a classroom where there's background noise, and so a child wearing a mini mic, the teacher can wear a mini microphone and the child directly stream from the teacher, so get dramatic improvement in their understanding because of the reduction in the signal-to-noise ratio. The most recent system, the N7, has Bluetooth capability as well, and that is an improvement. And also, there's an improvement in mapping, whereas it used to be that the child had to be wired up to the computer, whereas now they can be Bluetooth connected, and it gives much more flexibility for the clinician and for the family. And there was discussion yesterday about the intraoperative testing. For many years we've not had an audiologist come to the operating theatre. But for some time we used to do our program, do our own NRT and impedance testing using the computer. And so having an intraoperative remote, which was much more user-friendly, made it easier for us surgeons to use. And the audiologists, then they download this remotely, separately, and then they have the data, but there's no need for the audiologist to come to theatre. We don't have the time and the resources to do that. In the future, there's no question we'll have cloud-based data management, and now that the patients all have an iPhone or a Bluetooth system, they can link in to Cochlear or to the clinics, and we'll be able to manage them remotely much more easily. I talked yesterday about electrode development, but I think an interesting thing is if the electrodes are going to be refined and closer to the neural populations, then we're going to need better stimulation strategies. And currently we can stimulate either monopolar, bipolar or tripolar, which give different levels or ranges of stimulation. An interesting new technology is so-called phased array or multipolar stimulation. And this, rather than having monopolar, where you have a stimulus which stimulates a broad population of neurons, in theory focused multipolar stimulation, where all of the electrodes are active and then there's a peak, in theory can give much more focused and smaller population of neurons stimulated at the one time. We've studied this using a percutaneous plug system because currently this technology is not available through the external processor. And so a number of patients who had a direct connection between the percutaneous plug and the electrode, so they can take home a sound processor that connects to that, or they can be tested on the benchtop laboratory testing to try to optimise these type of stimulation strategies. And there have been quite significant improvements shown in the so-called all-polar or multipolar versus the monopolar stimulation. Electroacoustic stimulation, again we talked about yesterday, is very accepted in adults and also in some children, although it's much less common that we see children requiring electroacoustic stimulation. But it's the strategies to preserve hearing that are really evolving. And we've talked about electrode choice, but I think the very topical thing is the intraoperative monitoring. Luke Campbell in Melbourne is one of our surgeon scientists, and he helped to develop this cochlear response telemetry or intraoperative electrocochleography system, where we can use an acoustic stimulus via a tube phone and then directly record from the electrode inside the cochlea. And this is the research system that he set up, which is now being developed into a commercially available system. I'm not quite sure when it will be available, but hopefully before long, because I think it is a marvellous tool to help us understand what's happening at the time of surgery. And here's an example of a slim straight electrode being inserted, and you can see that shake you get when you're trying to do it slowly. It isn't easy to have a very still and steady insertion. And the amplitude of the cochlear microphonic gradually rises as the tip of the electrode gets deeper in and closer to the region of here, closer to the 500 hertz point. And so here's an example on the left where hearing has been preserved after electrode insertion because the as this is the duration of insertion, and the amplitude of that wave has gradually risen and is maintained at the peak after insertion. Whereas in this example, the amplitude has risen and then fallen again, and that loss of the electrocoagulography response is also associated with loss of hearing post-operatively. What have we learned from this? Well, when the ECOG is preserved, it tends to be associated with early hearing preservation. Interestingly, very rarely do you see a change or a loss of the ECOG response before approximately 20 millimetres of insertion. So it appears that once you get to that 360-degree point, that's when there's a change, or the electrode perhaps impacts on the basilar membrane more, and that's where changes might occur. But interestingly, if the electrode is slightly withdrawn, that can be associated with a return of the waveform, which perhaps means that it's not so much a pressure effect, but rather a direct contact effect. And as Ganesh was pointing out, electrode and cable manipulation can be associated with change in the ECOG, and maybe it is a direct pressure effect or something happening inside the cochlea. And hopefully, if we can be less traumatic with our electrode insertion, then, as I said yesterday, we'll get less of this tissue response, and that will improve our longer-term hearing preservation. It's also now known that there's an association between endolymphatic hydrops and that tissue response. And so the mechanism may be a hydropic response within the cochlea that causes that delayed hearing loss. As Ranjit was saying, a new and interesting technique of cortical measurement of hearing function is functional near-infrared spectroscopy, which uses a light or LED to detect saturation changes in the hemoglobin inside the brain in response to stimulation. And of course, MRI is difficult to measure brain function in implant canals because of, or even in hearing canals, because of the loud noise associated with the MR process. And CT, of course, is difficult in children because of the radiation. And so this technique is non-invasive and very safe. And so we hope that, this is from Stefan Wieder, who is our recent fellow who's recently returned to Switzerland. He's demonstrated that we can use this to measure thresholds, and the hope is that this might help to better understand cortical encoding of hearing. It might help to find prognostic factors in implant candidates and outcome, and perhaps assist in mapping and adjustment of implants. So we have a number of ongoing studies using this with implant recipients. Also discussed yesterday was the now understanding that dementia is a dramatically increasing public health problem, and that it's been stated that the largest single modifiable risk factor for dementia is hearing. And the association is very clear. What we can do about it remains uncertain. And so the question really is, does treating hearing loss delay cognitive decline? And whilst it is definitely, or probably, a common pathological process, is hearing loss truly a modifiable factor? So if we provide hearing aids where appropriate, or cochlear implants where appropriate, does that alter the progression to cognitive decline? Frank Lynn has got a large study going in the United States, but that's using hearing aids. Julia Sarant in Melbourne is running a prospective longitudinal study where we're comparing cochlear implants with a healthy aging control group. We have some evidence from previous study where we looked at the mini-mental scores after 2 years after cochlear implantation, and although it's very subtle, the average across these patients shows that 2 years later their mini-mental score improved slightly rather than deteriorating, but this is clearly not statistically significant. The longitudinal study, we hope, will give us more information, and we hope to recruit 400 recipients over age 60. But even early on, looking at the first 40 or so patients, there is clearly an association with executive function, with being significantly worse with increased hearing loss, with each 10 dB of hearing loss predicting a reduction in executive function of score with a significant effect size. So hopefully longer term follow-up will reveal the effects of the benefit of cochlear implantation. The totally implantable cochlear implant is very topical. You've all heard me talk before about it's over 12 years ago that we implanted the first 3 subjects with the Tiki. And the problem with that device is that whilst those subjects are still using the implant, the battery is still working, the function is still good, they heard a lot better when they wore the external processor. And the problem with body noise and just attenuation of sound with the package-mounted microphone was significant, and so the degree of benefit was not what we had hoped for. But as has been publicised, we're now using the Carina microphone on a Tiki implant and have commenced a study to look at the outcomes. And a number of patients have been implanted, and I can report that it's encouraging the outcomes, but so far I can't really discuss the results until we've completed recruitment and the outcome. So I'd like to finish with a different direction, and you're all familiar with bone-anchored hearing aids and osseointegration. And we've also done a study with a new investigational device, the so-called Ossea system, which is a piezoelectric transducer, which is then connected to a standard osseointegrated screw fixture, and the device is driven effectively by a cochlear implant receiver stimulator, and they wear an external sound processor, which is similar or the same as the Kanso type sound processor. There's some surgical tools and intraoperative test system and fitting software, and we've implanted 12 patients, some with single-sided deafness, some with conventional types of conductive loss, and it's a somewhat complicated plan to position both the receiver stimulator and the transducer, but relatively straightforward. A screw fixture is put in and a guide pin then used, then a clearance indicator is used to confirm or to make sure there's no bone that will impede the fitting of the transducer, and then it's a freedom type sound receiver stimulator, so a well is drilled for the receiver stimulator package, and then the system is tested, and then the transducer is secured to the screw fixture in the same way as a Baha Attract would be secured, and then it's closed up. So for the group overall, again, we can see a pre-op unaided sentence reception threshold, and preoperatively using a soft band with a BP110, so the more powerful sound processor, you get a significant benefit. And then with the Ossea, we get an even greater improvement in their sentence reception threshold. So 2 examples. This is a first candidate who was a woman with Treacher-Collins syndrome who had never had a bone anchored implant. She'd only worn standard bone conduction hearing aids. And this is her preoperative threshold, and the purple is with the BP110, and then the darker blue with the Ossea. And the very dramatic thing, I think, is the very good thresholds in the high frequency. So this piezoelectric transducer gives excellent high frequency sound transmission. And this is the matrix sentences, again, up to 12 months, so very good long-term benefit as we would expect. But the other interesting thing is that for single-sided deaf patients, whilst I debated for a couple of these whether they should have a cochlear implant or a Ossea, those that have received the Ossea are very, very happy with the outcome. And it makes me wonder to what extent with a cochlear implant we are simply allowing them to attend to sound on that side, and whilst they do get some measurable benefit with a cochlear implant, in fact what they're doing is hearing on that side so they can then attend with their better ear. Whereas the Ossea patients, they get good transcranial transmission, so they're getting much better quality of sound to their good ear from their deaf side. And once again, this is the single-sided deaf patient, and again, very good high-frequency transcranial sound transmission, which we don't see with conventional BAHA, either the percutaneous or the transcutaneous type. And again, unaided with the BP110 and then with the Ossia. So our experience has been really very satisfactory with the system, and the surgical procedure is straightforward. I think there will be further improvements in the type of the device with time, and we're currently trialling an improved external processor as well. So I do think that this is going to be a very useful product, hopefully in the relatively near future. So what's the future? I don't think that robotic implants is going to put us all out of business in the near future. But I do think that robotic assisted electrode insertion probably will have a role to improve the electrode insertion once we've got everything exposed. But to be doing totally external robotic procedures is, I think, it doesn't provide an advantage over what we can currently do. So I'll finish there, and thank you very much. Question?
Talked about single-sided deafness and tinnitus. There are some patients who have unilateral single-sided deafness. They come to us, say, I'm okay with it. After a few years, once you say that, these are the options, you could undergo a cochlear implantation. After a few years, he comes and says that, I'm now bothered with tinnitus more than my hearing loss. Now, would you advise a cochlear implant in this situation?
Probably not. If their main complaint is tinnitus, then in our experience in Melbourne, that those patients are the ones who are not happy with their outcome, because they don't get total abolition of tinnitus, and they may or may not get a beneficial hearing improvement. So if their main complaint is the tinnitus, then we are very cautious about recommending an implant. So I'm interested in what Ganesh thinks, but that's our approach. If they want to improve their hearing, then we're much more interested to try to help them, because they seem to be a much more satisfied group than those who just are worried about their tinnitus.
Thank you.
Thank you very much.